All right, we're going to get started, and I'd like to begin by welcoming everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. And in today's webinar, it is about neurological issues with vasculitis with Dr. Shafiq Karam. Let me begin by introducing our guest today. Dr. Shafiq Karam is a neurologist at the Hospital of the University of Pennsylvania, a professor of neurology at the University of Pennsylvania, chief of the Neuromuscular Division, and director of the Neuromuscular Fellowship Program at the Hospital of the University of Pennsylvania. He specializes in peripheral neuropathies and is involved in various clinical trials in neuromuscular disorders. Dr. Karam completed his medical training at St. Joseph University in Beirut and his residency in neurology at Mount Sinai Beth Israel in New York. He did a fellowship in peripheral nerve pathology at the Mayo Clinic in Rochester, Minnesota, and another fellowship in neuromuscular medicine and EMG at the Partners Program, which is Harvard Medical School, Brigham and Women's Hospital, Massachusetts General Hospital, and Boston Children's Hospital in Boston. So welcome, Dr. Karam. We're so happy to have you with us today.
Well, thank you for having me.
And before we get started, if you could let us know if you have any disclosures today?
I do not have any disclosure relevant to vasculitis or to this talk.
Okay, thank you. So everybody, today we're going to begin with some polls. We would like to ask you some questions and have you participate so that Dr. Karam can comment on them. And I'm going to get started with that. So you should see the poll coming up on your screen now. It has, let's see, 2 questions. We'll give everybody just a minute or 2 to go ahead and answer those questions. All right, just another minute, and I'll end the poll in just a minute, and we can all see the results, and then I will let Dr. Karam comment on anything that he sees. All right, ending the poll now, and you should be able to see the results there, Dr. Karam.
I do, yeah, thank you. And thank you for everybody who answered. Obviously, we will probably have a little bit of biased attendees here because you guys are interested in this talk, probably because you have some degree of neuropathy. And this is reflected in this poll. So over half of you have neuropathy. And of those who have neuropathy, most of you have neuropathy related to the vasculitis. And then a small percentage, 7%, don't have neuropathy at all. Another small percentage, 7%, have neuropathy from something else. And that's important, right? Because we don't want to blame everything on vasculitis and miss other treatable conditions like vitamin deficiency or diabetes, etc. And then interesting, there's 30% who don't know. And it's good for me to give this talk because I will show you what is peripheral neuropathy. So hopefully by the end of this talk, you will know if you may have peripheral neuropathy or not, based on the symptoms that I will be discussing. And if you suspect that you may have it, then it would be a good thing to see your physician and ask about it. Because if it's diagnosed, then the treatment and management may be different. And then regarding the symptoms of peripheral neuropathy, are they well controlled, partially controlled, or not controlled? So unfortunately, the majority of you have partially controlled symptoms or not controlled symptoms at all. Only about 13% are lucky to have neuropathy being well controlled. So we will talk a little bit about how we try to control neuropathy, and hopefully in the future we'll have new drugs that can also control it. But we do have current drugs that are pretty good. So hopefully we can get more people in the partially controlled, because we do want to be realistic, and maybe some more in the well controlled. I do understand that not everybody's going to be completely controlled. But hopefully we can improve the not controlled at all, because that's obviously sad, and this is definitely going to impact significantly the quality of life.
Well, thank you for sharing all that information with us about our poll, and thank you to everybody for participating. And now, Dr. Karam, as soon as you're ready, if you would like to go ahead and share your presentation.
Okay, so here we go. Do you see the slides the right way? We want them?
do.
Okay. So again, welcome and thank you for being here. And I look forward for the questions. This is a talk that obviously it's the first time I'm giving it to you. This is the first time that the Vasculitis Foundation has invited me to speak. And I think it's because some of you may have seen me speak at our University of Pennsylvania Vasculitis conference that we have held, I think back in May 2024. And it was a conference mainly for patients. We had patients come over, and we had rheumatologists talk about different type of vasculitis, different treatment, research, etc. And I was asked by one of my colleagues, Dr. Merkel, who together we kind of see a lot of patients together. We have type of multidisciplinary clinic to speak about neurological manifestation of vasculitis. And it's an interesting topic. There's not a lot of research going on, unfortunately, in the neurological manifestation of vasculitis. But the diagnosis is important because we know the earlier we diagnose patient, the better the outcome. And these are treatable conditions. So the earlier we recognize the symptoms, and some of patients with vasculitis will present first with neuropathy symptoms. And that's why it's important for neurologists to recognize these symptoms. And for the patient to recognize symptoms of neuropathy, because sometimes you may have worsening and it may be related to active vasculitis and you may not know. So a lot of time, actually almost always, we see the patient together, meaning that Dr. Merkel or one of our vasculitis expert here at Penn sees the patient and they refer to me, or vice versa. If the patient presents to us first in the neurology department, we would see them and then send them to our rheumatology group for evaluation and discussion. So this is the outline of today's talk. We will start by discussing classification, how I think about vasculitic neuropathy, and then how neurologists in general think about the nervous system. They like to separate the nervous system into central and peripheral. And then we'll talk a little bit what is vasculitis, because it's important to understand what happens in vasculitis and why it's important to diagnose it quickly and treat it early. And then we'll talk about what are the symptoms, because that will help you recognize maybe that you may have some symptoms of neuropathy. And then, the CNS vasculitis, we still have it here. Dr. Merkel, for some reason, told me, let's remove that. And I'm not a CNS expert, so we're not going to talk too much about that, but it's important to recognize that the brain can be affected in certain type of vasculitis. Then we'll discuss what kind of testing we do with the peripheral nervous system to diagnose peripheral neuropathy and to determine whether there's vasculitis in the nerve or not. And then finally, I'll stress again the multidisciplinary approach and its value in the management of patients with vasculitis, especially those who have neurological involvement. So let's start with this classification. This is how I classify vasculitic neuropathy. Systemic vasculitis, the word systemic means that all the body is affected. And in this situation, a lot of time it's a little bit easier to recognize why the patient has vasculitic neuropathy, because there are other signs. You have the skin that can be involved, the kidney that can be involved, the lungs, sometimes the upper respiratory tract, and other organs. So it makes it easy a little bit for the physician to say, well, there's multiple organs that are affected. Things are getting worse relatively quickly. Let's think about vasculitis. And usually the diagnosis of vasculitic neuropathy is made a little bit quicker. Whereas in non-systemic vasculitic neuropathy, and I wish I put a poll question here asking if any of you had non-systemic vasculitic neuropathy, This is when the vasculitis is only affecting the nerve, but there's no kidney or skin or heart or GI tract, etc., involvement. And unfortunately, in those cases, the diagnosis may be delayed because people would not necessarily think about vasculitis in those situations. And when you have a systemic vasculitis, we try to determine if this is related to ANCA vasculitis or polyarthritis nodosa or cryoglobulinemia, because what's causing them is important. For example, many of you already probably know, because you are expert in these diseases, a lot of patients with polyarthritis nodosa have a virus infection called hepatitis B. And a lot of patients with cryoglobulinemia may have another virus infection called hepatitis C. And just giving immunosuppression may not be enough. You also need to treat the hepatitis C, for example, to better control the disease. Sometimes there's malignancies that are involved in cryoglobulinemia that also needs to be diagnosed. Sometimes there's a rheumatological condition such as rheumatoid arthritis or Sjögren's syndrome that's causing the vasculitis, and that need to be addressed. Certain situations, you have an infection with HIV or other Lyme disease, etc. Certain drugs, we reported on a very benign antibiotics that can treat acne. A lot of young people take it, called minocycline. And we've seen a few patients develop vasculitis with minocycline. So side effect of drug is important. So you have to stop the drug. Obviously, you cannot continue taking that, and you have to avoid it in the future. And then, unfortunately, in certain situations, also vasculitis can reveal malignancy, such as lymphoma and so forth. Now, why it's important to understand how neurologists think about the nervous system. And that's, something that sometimes is frustrating to patient and other physician, but neurologists try to separate the central nervous system, which is here colored in purple. You have the brain and the spinal cord, versus the peripheral nervous system, which are these kind of yellow cables that exit the spine, and they go to the hand and to the feet and to the GI tract and to the heart, and etc. So why we like to separate those two? Because usually the condition and the diseases that affect the central nervous system and the peripheral nervous system are different. And the doctors that specialize in one or the other are also different. And the testing that we do for these different conditions is also different. So today's talk is going to really be focused on the peripheral nervous system, because that's what I mainly specialize in. But it's important to recognize that vasculitis can affect both. Most of the time, it is the peripheral nervous system, but sometimes, unfortunately, it can affect the brain in rare instances. The other thing to recognize is that this is a nerve, okay? You have the axon here, and you have, the body, and then you have the axon. And around the axon, you have what we call the myelin sheath. And in disease that cause abnormalities of the myelin sheath, recovery is very good. But in diseases that cause abnormalities in the axons and damage to the axons, the recovery is not very good, okay? And that is what happened in vasculitis. You have damage of the axons. So the recovery is not very good. And that's why it's important to diagnose very early and treat aggressively early to avoid additional axonal damage. This is a nerve from a 17-year-old patient who developed vasculitis. There was a delay in diagnosis because they thought maybe she had ulnar neuropathy at the elbow. She underwent surgery, etc. But unfortunately, you see here, this is the blood vessel in the nerve. And what you can see that there's really an angry inflammatory collection here within the blood vessel wall. Usually this is a very smooth and not very thick and not distended, but you see these kind of purplish dots here, or dark blue dots. These are inflammatory cells within the blood vessel wall. And this pink material here is necrotic debris. And this is what we call a necrotizing vasculitis. And what happens in vasculitis is that you have damage to the blood vessel wall, an occlusion of the blood vessel wall. And when you have occlusion of the blood vessel wall, blood does not flow to the organs anymore, and specifically here to the nerve, as you can see in this area here. And there is lack of oxygen and nutrient to the nerve, and the nerve basically degenerates and doesn't work anymore. So it's a lot of time, I don't know if you heard neurologists say, oh, well, time is brain. If you have a stroke, you have to call 911, etc., because this is exactly what's going on. You have interruption to the blood flow to the brain. In vasculitic neuropathy, you have a similar process where you have interruption of the blood flow to the nerves, and you have to try to treat patients and diagnose them obviously early and treat them quickly. So you have to avoid these kind of irreversible nerve damage. And that's why it's painful. You have lack of oxygen to your nerves, etc. This was in the acute setting. Now, in the chronic setting, with the body to try to kind of, you see this is occluded blood vessel here, to try to compensate, what happens is that small blood vessels try to, make a way. You have kind of revascularization, we call it here. You can see here, small blood vessel. Obviously, they're not as good as this big one that is occluded, but they're trying to help the blood flow to the nerve come back. And this is why we do have some improvement. So I tell people, don't lose hope, because there's some improvement if we treat patients. And this is what you see in chronic condition. So there's always hope that people will get better, but unfortunately, it's not going to be back to what it was before the vasculitic attack. Okay, so we talked about vasculitis. This is what happened. You have blocking in the blood vessel. You have inflammation in the blood vessel that blocks the blood flow and causes organ damage. What are the signs of neuropathy? So if you do have this issue with interruption of the blood flows to the nerve are going to suffer, and they're going to send a signal to your brain saying there's something wrong. Hey, I feel like there's a burning sensation in your feet or in your hands. I feel that there's a tingling, there's a numbness, lack of sensation, there's sharp electrical pain. And then if the motor nerves is affected, you're going to have difficulty with opening jars, tripping on your feet because you have a foot drop, you have hand weakness, atrophy of the hand muscles, and so forth. So all of these things are obviously uncomfortable, but they are suggestive that there is peripheral neuropathy. And what is typical of vasculitic neuropathy is that these happen in an attack. You have an attack of a nerve in one foot, then in the hand. Like, for example, I saw somebody earlier today, the right foot start getting numb and painful. Then the left foot start getting, a week later, then 2 weeks later, the right hand start getting weak and develop a wrist drop. So these are things to understand how the disease progresses. And if you don't treat it, it will continue to progress. Okay, so you have these symptoms, and when should we suspect that this is a vasculitic neuropathy? Now, obviously, if you have a known rheumatological disorder, so if you have known rheumatoid arthritis or Sjogren or ANCA vasculitis or PAN, and you have these symptoms, then it would be hopefully easy to recognize that there's something wrong and act upon it very quickly. Another way we teach our fellows and residents is that you have muscle weakness with the neuropathy. That is something that is not common in the neurology world. And when you see these two combinations, then you have to think about vasculitic neuropathy. And then, as I just mentioned, you have an interruption to the blood flow. So you have all of a sudden weakness and pain and numbness and tingling. And a lot of times it's affecting one limb more than the other, etc. And then finally, we tell people if you have any neuropathy that's just keep getting worse, it keeps progressing, the patient is getting weaker, more balance issues, etc., more disability, then this should be worked out further, obviously, and a biopsy could be conducted to see if there's a vasculitis or any other process that is going on. Okay, I think I've repeated that many times, but it's very important. Rapid progression and nerve damage We do have to diagnose early and treat early. And this is your role. You are patients, yes, but you are educating also your physician, because these are rare conditions. And when your physicians see them and learn, they learn from you. And then if this happens in a different patient, they will recognize it right away. A lot of time, the most we learn is not really from books, is from patients. And this is what the Vasculitis Foundation is doing as well, is raising awareness about these conditions, and hopefully people are listening and learning and recognizing that these are issues, so we can treat them, address them early, and prevent disability in the future. Okay, so we get questions asking us, what do we do to determine that there's a neuropathy? Okay, so one of the first, we already took the history, and then we suspect neuropathy because you have the pain, the numbness, the tingling, the burning sensation, the weakness, the loss of dexterity. And what we try to do is that we examine the patient. Okay, so this is this handsome fellow here was our fellow a couple of years ago. Now he's a physician in Canada. So this is what we do. We check the reflexes, and then we check the strengths, we check the sensation. And if there's abnormalities there, then it would be suggestive of something's wrong with the peripheral nerves. You can see here we're looking how strong the patient is. And your neurologist should be doing these tests to try to determine if there's, and we're comparing side to side, obviously, and we're checking, making sure that there's no deficit anywhere. A lot of time the patient would notice, obviously, that there's something wrong, and the physician needs to confirm it on the exam. This is a tuning fork to try to see if they can feel it correctly or not. Now, this video is a little bit sped up, by the way, so I'm not that fast in real life. Okay. Another thing that we really rely on a lot is nerve conduction study, and some of you may have had this test. This is where we stimulate the nerve with an electrical pulse. It's not a very comfortable test, unfortunately, but this is one of the best tests we have to diagnose objectively peripheral neuropathy or other problem, carpal tunnel syndrome, radiculopathy, etc. Because there are other issues that arise in people with vasculitis. So carpal tunnel syndrome, which is a pinched nerve at the wrist, causes numbness in the hands, and sometimes wake up people from sleep. They have to shake their hand, etc. If they're on their phone, their hand goes numb. It's a common problem, and it's not necessarily related to vasculitis, but it could mimic something wrong that is related to vasculitis. So the nerve conduction study would be helpful in those conditions. Sometimes there's a pinched nerve in the back that can also look like vasculitis, but it's not. It's just a herniated disc that can be treated as such. So not everything needs to be treated with steroids, rituximab, and Cytoxan. Some things are more of a mechanical nature and need maybe surgical intervention or physical therapy and so forth. So we have normative data here. I'm pointing to that. We look at how quickly the nerve conduction study is going, how quickly the signal is arriving, and how large the amplitude is of the response. Okay, other things that we do, and probably all of you know these by now, we do blood testing, we do urine testing, we do imaging, CT chest, for example, and people with ANCA vasculitis. We do sometimes biopsies, because biopsies are important to prove, as I showed you in the picture, that there's inflammation. Now, one thing to understand is that if the biopsy is negative, it doesn't rule out vasculitis, because vasculitis is a patchy process. So if you organ biopsy an area, and unfortunately that area is not affected by the disease, you're not going to see it. So again, you really have to go by your clinical impression and suspicion, your other testing, and not just the biopsy. But the biopsy is extremely important. This is again to stress the point. So on nerve biopsy, we only see it in about 50% definite biopsy. So that's why a lot of time we request to have also a muscle biopsy in addition to the nerve biopsy. But even with those, we're still not 100% diagnosed. And that's something that is obviously frustrating, not only for the patient, but for the physician, because we do want to have a definite answer. But unfortunately, it's not always possible. So sometimes we have to go by suspicion, clinical impression, and so forth. Okay, this is another patient that we biopsied. The nerve was completely normal, but the muscle showed that he had inflammation in the blood vessel. You see it here. Um, and although the muscle is normal, by the way, but we did find an inflammation in the blood vessel. And that's how we made the diagnosis of vasculitis. Okay, so what does the biopsy consist of? Biopsy can sound scary, but but sometimes it's an important procedure. And sometimes we do it in the outpatient. You see here, my fellow is doing it with me. And we just do it under local anesthesia. It doesn't have to be an admission to the operation room, etc. It doesn't have to be a big process. We don't admit patient to the hospital for a biopsy, at least for the nerve and muscle biopsy. We do them under local anesthesia, and it takes about half an hour to an hour, and the patient walks out of the clinic. So I know they're not pleasant things, but sometimes when we don't have a definite diagnosis and your rheumatologist really wants an answer, we can perform this procedure in the outpatient setting, or the surgeon can also do it in the outpatient setting. Now, we talked a lot about the vasculitis and so forth, but how do we treat the vasculitis? So there's two parts of the treatment, okay? There's the treatment of the underlying autoimmune process. You do want to stop this angry inflammation in the blood vessels. So we do give steroids, infusion with rituximab, cyclosporin, cyclophosphamide, pills with methotrexate, azathioprine. There's many different medications that can be given to target specifically the autoimmune disease. And a lot of time, this is driven really by our rheumatology group. Actually, they like to handle these autoimmune suppression. Now, obviously, if we see the patient first and the rheumatology appointment is in 2 months, we have to start treatment. So we do it ourselves. But they prefer, and I agree with them, that they like to start the treatment. But what about the symptoms? Yes, once there's nerve damage, the signal going to the brain is not going to stop. Your nerve is still going to send a signal to the brain saying, there's something wrong, there's something wrong. Although you tell your brain, well, I understand there's something wrong, stop bothering me. The nerve cannot get this message. They're still telling you there's burning, there's tingling, there's numbness, there's discomfort. So this is when we give medication to kind of dull the pain, numb the pain. We give people gabapentin or pregabalin or duloxetine or nortriptyline. You may have heard of all these medications. And a lot of time, we may need a combination of these drugs to help control the symptoms as much as possible. We try to avoid opiates chronically. Sometimes we do need them in the short term, but chronically, we know that there's something where people get used to them, and then the dose does not work anymore. You have to go up and keep increasing, and then you run into trouble with respiratory failure and constipation and so forth. So and many studies have showed that long term this is not a good. So that's why we try to avoid. But we try to give medication that better control the pain, and we try to combine some of them to see if that can prevent things. We also, suggest alternative medication. Acupuncture sometimes, massage therapy, sometimes soaking your feet in a little bit of cold water with crushed capsule of aspirin, and it can help. Sometimes topical cream, lidocaine, or a combination of different compound cream can be helpful. Sometimes it's not 100%. We're not able to control 100%. Now, something is important. If you do treat the autoimmune process, a lot of time the neuropathy does get better, and even the symptoms are well controlled. So a lot of time in my patient down the road, we are able to reduce the amount of neuropathy symptoms medication, because these medication can also have side effects, right? So the gabapentin makes people drowsy. Sometimes they get swelling in the legs. Sometimes they get a little bit of weight gain and so forth. Other drugs such as the tricyclics can give severe constipation, lightheadedness, and fatigue, etc. So we try to minimize the number of medication that people get. I mean, you don't want to be walking pharmacy, but sometimes it's unavoidable. Unfortunately, you have to take many, especially early on, but then down the road, once the disease is well controlled, we can lower the amount of medication, hopefully, and the patient quality of life will improve. Obviously, if there's weakness and dexterity issue, we can recommend physical therapy, occupational therapy, and so forth, and all of these important. I mentioned something, but I would like to stress it again, is that when people develop neuropathy and their disease is well controlled, so they are, for example, on rituximab, etc., and they're doing fine, there's no other organ involved, but then they have symptoms of neuropathy or something happens, it's important to work this up, meaning try to understand why the patient neuropathy. It's not always a good strategy to assume that the neuropathy is related to the vasculitis. You want to make sure that there's nothing else that's going on. I'll give you an example. A patient can develop vitamin B12 deficiency and develop symptoms of neuropathy, or another patient can develop diabetes, which is one of the most common cause of neuropathy. And we need to diagnose these things because the treatment is obviously different. Another thing is that some people can get a herniated disc or spinal stenosis or carpal tunnel syndrome or pinched nerve in their neck. These symptoms can potentially be mistaken for vasculitic neuropathy, but if the disease is well controlled, you really have to investigate what is going on and make sure there's nothing else going on. So whenever we see a patient with well-controlled disease, we are looking at other problems that could explain why the patient is having worsening symptoms or new symptoms of neuropathy. Okay, I'm going to summarize here. Remember that peripheral neuropathy can be a manifestation of vasculitis. Neurological evaluation can determine whether there's neuropathy or not, and what's the cause of the neuropathy. And the treatment, the earlier the treatment, the better. You know, we can't wait until things get really bad because sometimes the recovery may never happen. In certain cases, we do need to get a biopsy, which is an invasive procedure, but it's not that bad. And then it's extremely important to collaborate between neurologists and rheumatologists because, you know, one person, this is a complicated condition, complicated disease. It's very hard for one expert to really understand and care for the patient very carefully. And it's very good to have a neurologist and a rheumatologist. Same thing if you have kidney issues, your rheumatologist is going to involve a kidney doctor as well. So if you have a neurological issue, it's important for the rheumatologist to involve the neurologist. Okay, so thank you very much for listening. And then now we are going to take questions, Kathy, correct?
Right. So you can stop sharing your screen if you
I
don't
will
mind.
stop sharing the screen.
And we will take some questions. And while there are a few questions in there, but while we're waiting for a few more to populate, this is where your webinar host, who is also a vasculitis patient living with MPA vasculitis, might comment on something. Somebody wrote in and said that they were concerned about the nerve conduction study. They were actually terrified because they heard such bad things about it. And I had one about this time last year. I had tingling. I have vasculitis, and I had tingling and pain and numbness in my left hand. And so I was sent for an ultrasound to make sure I didn't have a blood clot because I have had some blood clots. And then I was sent to have the nerve conduction study. And it was uncomfortable, but it was not terrifying. And it was not incredibly painful. But I know that people have heard that story. So actually, my producer in the background asked me to share my story. So I just wanted to tell you all that I don't think it was awful, and I want you to know that so that, as Dr. Karam said, early diagnosis is important if it is nerve damage. Mine was not. Mine was carpal tunnel. I got a shot in my left wrist, and it's been fine ever since. So it's been a year with no more problems. So
Yeah, thank you for sharing, Kathy. I mean, that's important, right? So because the carpal tunnel syndrome, again, the treatment is completely different from vasculitic neuropathy. So it's important to differentiate. And unfortunately, we don't have a much better test than the nerve conduction study to differentiate these conditions. So I totally agree with you. It's not the most comfortable test. I don't downplay, some of my technician, because the technician do the first part of the test, which is the nerve conduction, and then the physician come in and do the needle part. Certain places the physician does the whole test. But I try to tell the patient, this is I'm not gonna hide the truth. It's an uncomfortable test, but we try really our best to make it as comfortable as possible. We try not to, go crazy with the electrical stimulation and with the poking, etc. We try to do the minimal necessary to get to the diagnosis. And we do it only if it's necessary. So, but it is helpful. I do, but I'm not gonna hide the truth. It's not a very comfortable test. Most people tolerate it extremely well. It's unusual for a patient to, we start the test and tell me, oh, I cannot do that. It does happen every now and then, but it's extremely, extremely rare. 99% of people tolerate it fine. Some people even sleep through it, believe it or not. So,
Well, I wouldn't say I slept through it, but I did want to say it was uncomfortable, but I've had uncomfortable tests before. It was not, to me, it was not painful. It was uncomfortable, and there's a difference.
yeah.
So I'm going to move on to one of the first questions. We have somebody else who says, I have MPA. I also have numbness in my feet, ankles, and up into calves. They are numb spots in other spots of my body. My neurologist is not sure if it's related to the MPA or something else. I have checks every 6 months. I can still walk and drive, but I pay close attention. So there's not really a question in there, but did you want to comment on what she said?
Yeah, I mean, so numbness can be a sign of neuropathy, but it could be a sign of something else going on as well, right? Because I showed you the nerves that look like electrical wires coming out of the spine. So we tell people, when there's numbness, you want to differentiate, is this coming from the nerve or is this coming from the spine or from the brain, for example? So this is, I think, the first step. And the neurological examination can be helpful. There's some things that we go by, for example, the reflexes, if they're brisk and abnormal, there's some abnormal reflexes that we find that may suggest this problem in the spine. And if they're down or reduced or suppressed, it tells us maybe there's a problem with the nerve. The nerve conduction study can also be helpful because the question is, what's causing this? Is this the nerve? Is this the spine? Or is this the brain? So the first step is to localize where the problem is coming from. And the second, let's assume it's from the nerve. We confirm it with the nerve conduction study. And then three, is it related to nerve damage? Or is it that happened in the past? Or is this an indication there's something new going on that we need to act upon? So all of those, obviously I cannot answer these questions without assessing the patient, but I'm glad the patient is seeing a neurologist because they can help the patient determine. Now, if they're not sure, sometimes we're not sure, but the question is, well, what do we do about it? Should we treat additionally or not? And that's a question that the neurologist and rheumatologist would have to answer.
Okay, thanks. The next person says, I have large vessel vasculitis, giant cell arteritis, but I've been dealing with burning toes, not the big toes, just the small toes. Also, both of my ankles ache. This is 24/7. I guess he wants to know, should he be checked for that?
Right? Yeah, so for sure it should be checked. Typically, large vessel vasculitis do not cause neuropathy because the nerve have kind of the small artery that innervates them or the medium size. But there's burning toes. The question is, what's causing it? Is it, do you have another problem that's causing it? And sometimes there's something called idiopathic neuropathy where they don't find a reason. And if they don't find a reason, you still have to treat it. I mean, it seems 24/7, that's pretty uncomfortable. And I'm assuming it's affecting your quality of life and maybe interfering with sleep. And there's medication that could be helpful for that. So first, let's check what's going on. Is there's nerve damage? What is the nerve damage coming from? And then how do we treat it?
Okay, thanks. And a couple of our patients have the same question. I'm just going to rephrase it a little bit, but this one says, can mobility problems be totally masked by prednisone and then show up several months after weaning off prednisone, even though the vasculitis is not active?
Yeah, I've seen that sometimes, and I think it's possible. So not necessarily from neuropathy, by the way. It could be like somebody has arthritis, and prednisone is a very good pain medication. Okay, so if you have arthritis, you have pain, completely unrelated to vasculitis, by the way, and you go off on the prednisone, which was helping you with the pain, you will have some mobility issue from the arthritis. Again, I have to go more in details about what they mean by the mobility, what's causing the mobility issue. Is it pain? Is it more stiffness and so forth? An exam would be helpful. And but yes, we've seen that happen, and usually that's explication is that the patient has arthritis. Again, not an autoimmune condition, but a painful condition, and the prednisone can help with that. But obviously, the prednisone, the issue is that it has side effects, and probably just giving prednisone long term is probably not ideal in those situations.
Okay, thank you. A patient asks, is it unusual for a patient whose MPA, as far as serious kidney damage is concerned, is in check by rituximab, but who has confirmed asymmetrical nerve damage and resulting neuropathy of hands and feet? She's asking, is it unusual for it to have continued worsening, to have continued worsening of the neuropathy, even though her vasculitis is in check with the treatment?
Yeah, I mean that's a great question, and we see that all the time. And the question is is it active vasculitis? Because some organs may be better controlled than other, so that's number one. And number two, is there something else going on that's causing the neuropathy to get worse, like another medical condition? And number three, are we just dealing with nerve damage that happened, from the initial insult? And this is just kind of fluctuate. Some people have bad days and good days. So these are the important questions. And that's why seeing patients over time, doing the exam, doing the assessment is very important to determine if there's active disease or not. And these are great questions. Unfortunately, I can just give, kind of answer that they may not be satisfying, and I really apologize. But with that, I hope you understand this is complicated stuff. So unless we see people in clinic, we examine them, we do our testing, it's a little bit hard to answer really exactly, and with accuracy and certainty.
But I think it's helpful that you are answering them so that they know to go seek out more help.
Right.
And you're empowering them with information that they can go ask their doctors about. And that's what we told them today, is that you couldn't specifically diagnose anybody. The next question is, what should be done if exercise or massage of the affected area worsens the symptoms of tingling, burning, etc.?
Yeah, so that's a challenge, right? Because from one end, you want to try to make your affected area stronger by exercising it. But from the other side, you may be kind of irritating the nerve or causing the symptoms to get worse. And I think the answer is to, obviously massage, you may stop it. For the exercise, you may try to change your exercise routine, figure out a way. Again, assuming that the disease is not active and we're just dealing with nerve damage, is just figure out a way to do the exercise that does not hurt or does not exacerbate the pain.
Thank you. This patient asks if you have suggestions on how to find a neurologist who actually works with vasculitis and sees me as the whole person rather than only a certain part.
Um, it can be sometimes challenging to find a doctor that things work well. I mean, you have to understand at the end of the day, doctors are people too, so the personality may not work with everybody, but yeah, I think maybe you Kathy can help them, right? You guys have resources to figure out the doctors. I mean, I don't know which area they are, but maybe offline I can suggest if I mean I know a lot of doctors in the United States or outside even that I can try to connect them if necessary, if they're in an area where I can help, or I'm assuming that maybe you have resources where you know doctors that specialize in vasculitis that could be helpful.
We do have the Vasculitis Foundation website has a Find a Doctor tab. And so you can also reach out to we have specialists in the Vasculitis Foundation that deal with the public. So yes, that's a good answer. Reach out to us, please. I think that the next question is, I have ANCA vasculitis and had drop foot in both of my feet 2 years ago. Now I only have neuropathy in one. I don't take any medicine. I was on gabapentin for two years ago. My question is, can it go away or does it get worse as we age?
Yeah, well, so first of all, it's good that you have recovered. I mean, that's again what we mentioned during the talk is that people do recover some. The classical teaching is that, oh, vasculitis, you're not going to get better from your neuropathy. And, the answer is, I don't think so because people do get better. So first, let's look at the positive things is that, one of your feet seems to have improved significantly and the other one has improved, but not 100%. And that's not unexpected. Unfortunately, some nerve damage is permanent. Now, will things get worse in the future? They shouldn't. They should be just stable, right? So, your degree of weakness right now should not get worse over time unless there's something new that happens. So that's why it's important to keep an eye on things and, listen to your body and see how things are.
Well, that's good information. This next question, I hope I say these things correctly. There's some medical terms in here. What would differentiate vasculitic neuropathy, specifically mononeuritis multiplex, from neuropathy associated with infectious disease resulting from immunosuppression?
Yeah, that you do need to be evaluated for that. So it's not an easy answer. Infection causing neuropathy is rare, by the way, so from immunosuppression. But if it does happen, which it can, so it has specific features. So let's talk, and I don't know how much details we guys want to talk, but certain if you're very immunosuppressed, you can get what we call CMV, polyradiculitis, that can cause, pain and numbness and tingling in the legs and some bowel bladder issues sometimes. So the testing need to be checked with the viral load and lumbar puncture, etc. So we have testing to look for different viruses and see if they're active or not. It really depends on clinically what your doctor suspect, but they do have to have testing to confirm it. So you cannot diagnose it just clinically. You do have to check for viruses in your body and see if they're active or not.
Okay, thank you. I know that was a hard one. It was also hard for me to understand, so I appreciate that. Someone asks, why does neuropathy make your feet and legs cold?
Yeah. By the way, I'm just going to say something. These are great questions. I mean, this tells me that, and very challenging. So, and I like to be challenged, but these are really great. And this is a very informed and educated group, obviously. There's many reasons why people get cold with their neuropathy. So remember that the nerve don't only control the muscle and give signal about the skin temperature, etc. But they also control the blood vessel and the blood flow. So that's number one. You regulate your blood flow when limb is hot or cold. So that is impaired in neuropathy. Two, when you have neuropathy, a lot of time you lose a little bit of muscle mass, which also cause the limb to be colder. So these are at least two reasons why people feel a little bit colder when they have neuropathy.
Okay, thank you. And should a patient be referred to physical or occupational therapy when they have neuropathy?
I think so. I always propose this to the patients. And sometimes they don't have to go, forever. They just go once or twice and they get taught the exercise that they need to do and they just do them at home. So I think it's important to involve the physical therapist and occupational therapist in people with neuropathy.
Okay. This patient says, I struggle with neuropathy in my hands and feet, but have recently been diagnosed with the same issue in my rib cage. Is this rare? MPA diagnosis in 2013 and remission in 2014-15.
Yeah, I mean, again, it depends on the cause of neuropathy. Usually the one that affect the rib cage, these are most of the time diabetic. So I don't know exactly the details, but that could be something. But it should not be from the vasculitis. And if the vasculitis is well controlled, I suspect there's something else probably going on.
Okay. Another reason to get checked. This person says, I've been told that 600 milligrams of Alpha Lipoic Acid, I'm sorry, I don't know that word, daily helps you. Do you agree? Are there any supplements that you actually recommend?
Yeah, that if I'm gonna recommend a supplement, that's probably one of the ones that I would recommend. There's just not good evidence that it worked or it doesn't work. This studies are conflicting. They're not done, by the way, on vasculitis. They're more done on diabetic neuropathy, etc. So, but some people have told me that they felt better with this supplement. Some people have felt that there was no benefit. So I tell people if they're interested in trying a supplement, tell them, you can try that and see how, if it helps, great. If it doesn't, the side effects are very little. Most people tolerate it very well, and it's not a toxic or unsafe supplement. So, yeah,
Okay, thanks.
people can try it if
And
they want.
they can try. Also, I just had a question, sorry. Oh, yes, it's about Raynaud's. Is that considered part of peripheral neuropathy?
Not necessarily. I mean, Raynaud's is a phenomenon that can happen with or without neuropathy, with or without autoimmune diseases. So it's not directly related.
Okay, interesting. How is it possible for a patient with historical diagnosis of carpal tunnel to know if the tingling is carpal tunnel or vascular neuropathy?
Yeah, so the nerve conduction study would be helpful.
Mm.
There's certain in early carpal tunnel, it's usually related to position, and that's why a lot of people wake up at night and they have to shake their hands because they typically have their wrist bent like this or like that, and then when they wake up, they do this, and the blood flow goes back and it improves. If something is more persistent all the time, that can be either advanced carpal tunnel or it could be vasculitis. So the exam and the nerve conduction study are extremely important in that situation because they can help differentiate the two.
Okay, thanks. And we have time for just maybe two more questions, so I'm going to do that. But before I do that, I just wanted to ask Dr. Karam, is if we have more questions, which we have, than we can get to today, is it possible we could maybe get some answers from you in the future and maybe a pre-recorded thing that we could put out as a extra to this?
Yeah, for sure.
Okay, thank you. I kind of put you on the spot there, sorry. So the next question is, does a foot drop from peripheral neuropathy due to vasculitis require wearing a splint for life? If not, how does one find balance between using the splint to prevent worsening of the foot drop and using body weight to walk using a cane or walker to keep the muscle from becoming atrophied?
Yeah, so again, in the acute setting, you may have to use it, and the question is how much damage to the nerve there has been. So if the damage is really bad, then recovery is not gonna get better, and you may have to use the foot brace indefinitely. But if the damage is partial and there's reinnervation and the nerve grows back, then you'll get better. I would not be concerned about wearing the foot brace and that causing things to get worse because that's probably not going to happen because you're going to go to the physical therapy, you're going to learn the exercise, and you're going to be doing the exercises, and you're not going to be wearing constantly the foot brace. You're going to wearing it when you go outside, so prevent you from tripping. And then, but you can do in the meantime the exercise when you're at home, etc. And then you will notice that things are getting better if there's continued reinnervation to the nerve.
Okay, thank you. Uh, this this question seems like a good one for all of us. Is an ongoing relationship with a neurologist necessary if you've been diagnosed with neuropathy?
Not necessarily. I do discharge patients from my clinic, believe it or not. I do. Most of the time, we like each other, my patient and myself, and we like seeing each other. But if there's not much, if things are, there's a new baseline, things are good, there's no worsening, I don't want to waste people's time coming to the clinic and me just examining them. And especially if there's not much pain anymore and they're fine. So if they're okay and there's no new symptoms, they've been stable for a year or two or more, and there's nothing new happening, they don't necessarily have to come back. I tell them, come back just if something new happened, let me know right away. But if you feel that you're stable and there's nothing new, you don't necessarily have to come back.
Okay, well, that's good for people to know. I'm sorry we did not get to everybody's questions today. We did try our best. I've got a couple more things to do before we end today. And so I'm going to share my screen now. I just wanted to talk to you all a little bit about the VPPRN, which is if you're a patient and you would like, oh, I went up one screen, sorry. If you're a patient and you would ever like to know how you can contribute to possible cures and treatment in the future of your disease, the answer is to give your information to the Vasculitis Patient-Powered Research Network, the VPPRN, and it's very simple to do that. They do the research that helps drive our possible treatments and possibilities for cures in the future. So starting January 15th, the new forms will be out. I can't tell you everything about VPPRN, but if you would just go to their website, vpprn.org, if you have never heard of them, that will give you more information. And if you have heard of them, be on the lookout for an email coming shortly because the new forms will be released on January 15th. And they'll need you to complete them, and you'll get to see what other patients are going through and what their research shows us and how their research is impacting vasculitis. And finally, I just want to say thank you to Dr. Shafiq Karam, who spent his time today and gave a great presentation, making it very understandable, peripheral neuropathy and the treatments, and answered our questions very well today. And so a lot of the patients commented in the box how much they appreciated your time today. So thank you so much for spending your time with us today and sharing.
Thank you for having me.